So the topic that I'm covering today is patient engagement in research, which is a bit different. My disclosures, I have worked in patient engagement and patient-reported outcomes in a number of ways from a funding mechanism. And you can see my funding on the left, and I'm a consultant for a couple companies, mainly as it relates to getting patients engaged in the process of understanding how to research certain new innovations. What I want to cover today, the first part of the talk is going to be talking about what I consider translational patient-centered outcome research, which means that we actually take things from the patient themselves, what they need, and then we put that into the research process. And we do that through patient engagement. And I'll demonstrate it through an example in bladder cancer, but no matter what you do in your urology practice, keep your mind open because all of these things apply to any area of urology. And so I'll explain how we built that from the ground up to a very large trial that's going to answer a very important question in bladder cancer. And then at the end, I'm going to end with really useful tips that you can start today. If you're going to clinic, you can start them today to build engagement if this is a type of research that interests you. So what do I mean by translational patient-centered outcomes research? Well, when you hear the word translational research, you probably know this framework where you start with animal studies. So, sort of the basic science, safety, understanding how the drugs work in the body to testing in patients with the phase 2, phase 3 clinical trials, and then onward until you get to actually using it in the community. But what translational patient-centered outcomes research, we just substitute the basic science for this type of clinical research for going back to the people we do this research for, the patients. So this means that we're going to ask them what kind of research questions are answering really important questions to them, not just to us as researchers, and then using them to design a study that is really, really, really useful whenever they're going to make their clinical decisions. And also making sure that the outcomes we're measuring are the ones that they'll actually use when they make their decision. So in order to do that, we have to think about patient engagement in research. And so I wanted to have one slide to at least show what we mean by that. And that's research being carried out with or by members of the public or patients rather than to, about, or for them. So we're not talking about a patient subject enrolling in a trial. That's different. We're actually talking about a patient who is literally on our research team. They attend our research meetings. They give us the patient view that we are missing. And that's really important. There's a website at the bottom from Involve if you want to find out more. That's from the UK. But this is not brand new information. Back in the 90s, Sir and Ian Chalmers, who, if you've heard of the Cochrane collaboration, where you can see Cochrane reviews, it kind of synthesizes large swaths of information. He had the quote, "Would researchers be helped to do more relevant research if the public became more involved in planning and promoting the research?" And so this was always in the back of people's minds. But until the Patient-Centered Outcomes Research Institute, which is a funding agency in the US, came aboard in 2010, you really didn't see a lot of patient engagement in research. You can see this is scholarly publications. In 2010, there were very, very few. But then in 2012, they started funding some patient engagement type of projects. And then the research funds, the true research funds in December 2012. And you can see after the first PCORI funded projects ended in 2015, you can see a real spike. I end this at 2018, but it's continued to climb with now over 400 PCORI funded projects completed that are related to patient engagement. So there is a continuum of involvement in the patient sphere, and you have to decide what makes sense and what you're comfortable with. We have traditionally done and conducted researcher-led projects. So it's just the research team and that's it, But there's consultative, there's collaborative, there's patient-led. So consultative is whenever we listen to patients, we, bring some of their opinions in through discussions. Collaborative patient engagement is a partnership. which is more of what I do, where I include them on the research team. And then there's patient-led, where they're doing everything and they're actually leading the project. So you have to decide for your particular project which one makes sense, which one you're comfortable doing. But I would argue anything from consultative on, that's going to be better than just simply researcher-led kind of research. And then if you have a big study or a trial or whatever you're putting together, it's good to have a structure of organization. If you look at this, we have the executive committee, and these are the larger trials. You see this clinical coordinating center, the data coordinating center on the right. But what we also have is a stakeholder coordinating center. And what that includes is a national advisory board. These are people who make the guidelines. So when you know you have your results at the end, they're going to be the patient advisory board, so that you have that patient view in mind, and then a clinician advisory board, the actual urologist or other types of healthcare providers who are going to be using it in their clinic. So it's important to have those represented so that you don't have any blind spots when you disseminate the results that you worked so hard to achieve. So there's lots of engagement techniques, and the talk isn't necessarily, you could do an entire talk about how to engage patients. But, I would just say that, not to let this deter you. You just need to be personable. You need to just be listening, and you need to believe that they have something valuable to say. And I think that's a really, really good foundation to begin patient engagement in your research. But you can see there's lots of ways to do it in person. There's lots of ways to do it virtually. And in this time of the pandemic, here we are doing a virtual talk. There's a lot of opportunities. And I will say we've used a bit of both in our research, and a lot of virtual, since the example I'm going to show actually began around the time of the pandemic. So we really were forced to expand our virtual. So what are engagement? I want to convince you that it does matter. The first thing is that you can go right to the beginning, and that's how I sort of thought of engagement got started, almost 10 years ago. And that is thinking about how patients can inform the research you're going to do, even the topics you select. And then once you know what topics are most important, and these are you can translate to say, as a patient, what are the questions when you are facing the decision between this treatment and that treatment? What is the question that you just didn't have an answer to? And we know in medicine, there are many. That's what research is all about. What is that important question? And then once you have the question, if you know what that question is, what are the outcomes that matter when you pick between treatment A and treatment B? And then that informs your protocol design. And then bringing them into study conduct. Once you have that design and you're rolling out the study, how do you recruit patients? I mean, who better to tell you how to do that than a patient who would be, potentially eligible themselves? What would have grabbed their attention? What would their concerns be? How do you retain them in the study? All of these are really important. And then finally, once you have those valuable results, they're really meaningless unless you disseminate them, unless the people who need them know that they exist. So they can help you with that as well. So in essence, a lot of the evidence for engagement is that it grounds the research on the patient experience. It improves the quality of the materials we give to our patients. It informs how the patients access their information, and it changes how we as researchers communicate our findings so that our research results get out there. So just a really quick word about PCORI. So I had mentioned this is the leading funder of patient-centered comparative clinical effectiveness research. This is comparative clinical effectiveness research is when we know these have treatment A and treatment B, and we know they both work. We just don't know which one is the best for a specific patient. And that is where PCORI puts a lot of their effort, because that is very patient-centered, because the decision is up to that patient. And you could argue treatment A and treatment B, the better treatment really depends on the patient. Perhaps their age, comorbidities. We know that even in the clinical setting, there are times that maybe we push that patient toward radiation or push them towards surgery because of something specific about them. And that's what PCORI is trying to get at. What is the right treatment for the right patient at the right time? They also fund dissemination and implementation research, and they fund engagement. And so there's a bunch of funding opportunities that go from pragmatic studies to engagement awards, and they're contracts, not grants. So that's a little bit different. A contract, you really do have to say what you're going to do. So I'm not going to belabor this, but I just wanted to give you a flavor for how that's getting funded, at least in the US, and how that can be done, in that way. But I'm also, like I said at the very end, I'm going to explain ways that you don't need any funding and you could just get started with this tomorrow. So I always believe in storytelling. Really, there's nothing better, right? It just grounds us. We better understand the concept. So I'm going to tell you a story about my path, because, if I just told you it, it sounds like I had it all planned, but I didn't. And I want to explain how some curiosity, reaching out to folks, learning more can really open up a whole field of research that you didn't know existed. So for me, as you heard from the introduction, I'm really interested in bladder cancer. And about at this point, maybe it was 11 years ago, I went to my first Bladder Cancer Advocacy Network think tank. It's a conference, right? And there are conferences in Colombia and otherwise where you go in and you learn something. Beacon, it was the one for me. And when I went there, it was really striking because that conference was interesting. There were patients there and there were researchers. And I just thought that was a really interesting concept for a conference, because usually we see researchers or we see, clinicians and researchers, but we don't usually see patients. Well, in that same year, PCORI had put out a call for their engagement awards. And the engagement award advertisement said, hey, this is an award or a contract for those who see an opportunity I didn't feel like the researchers and the patients were actually collaborating. It was sort of, they attended, but there wasn't a lot of involvement. And I thought, maybe I can use these PCORI engagement awards to create something. And that small idea turned into a lot. And I'm going to show you how that developed over years. So I already talked about the evidence for engagement. And I put this up here again because I reflected on that. I'm like, well, where would I begin, right? Well, we begin at the beginning. Topic selection and prioritization. I didn't even know in the bladder cancer world what topics were important for patients. So we decided to first create what we termed the Patient Survey Network, which was the idea to engage bladder cancer patients and caregivers in research question prioritization. And we did this virtually. We already had a patient community. We needed to just organize it such that we could ask a patient a question and say, hey, these seem to be important questions. Are they? And if so, which one's the most important? And so we did this a number of ways. The first was that we had to recruit our patients and caregivers to join the Patient Survey Network. And we did this a number of ways. Again, a lot of it virtually. There's an online platform called Inspire. And there's a lot of patient advocacy out there. You just have to find it and look for it. Inspire is a platform on the web that a lot of patients come to ask questions of each other. It's sort of like a support community. It's like a support group that's online. So we use that, and we use Beacon because they are part of that to advertise that we are doing this. We did webinars so that patients who were interested would attend, ask questions. We sent out pamphlets to physicians around the country and said, hey, give this to your patients. If they're interested, maybe they'll do this. And then we did a guest blog post again about this as well. Then once we had, started to gain some momentum, we needed to generate research questions, because I think we knew it would be very overwhelming to say, hey, patients, what are the questions, the research questions that are plaguing you? They're not going to be able to just generate those. So we did this a number of ways. If some of you may know about the Delphi method, but if you don't, that's a really good method that you could investigate, apply. It's not that complicated. We used it at the conference, that think tank, the Bladder Cancer Advocacy Network conference. We had all of the people there, patients, clinicians, researchers, everyone. And we sent them a really quick survey at the conference. And we said, hey, for you all who are very well-educated individuals in your particular space, what do you think the most important questions are? And they would list them, okay? Then once we had that, we actually collated them because you could see many of them said the same question here, another question. And then we said, here, we sent a second survey. That's the Delphi method. You sort of whittle down. Now, here are the questions that came up. Which ones are most important? Okay. And then they ranked them. And then we had a meeting. And I love this. This is actually a true picture of our first meeting. And the interesting thing that you don't know, but I'm going to explain here, is everybody on that right, on that long table, they were the patients, and everyone on the left were the researchers and the physicians and the healthcare providers. And I didn't have assigned seats. So this is already telling that we're not used to doing this. Now we all mingle. It's just a different structure now. But because of their meeting, we were able to say, let's just whittle it down to a digestible number of questions. And then we can send that to Patient Survey Network and we say, hey, these are the big questions that came up. Please just rank them. And so maybe just 3 to 5 questions we did for each disease stage. For non-muscle invasive disease, there's going to be specific questions, right? For muscle invasive, same. For metastatic, something different. But importantly, we also allowed free text research questions that they could type in. And we do this every few years because it allows us to keep a finger on the pulse of what the needs are as our field changes. But we use that to populate the next survey. So those free text questions, we sort them, many of them come into a category, and then we can add them into a question. So it's interesting because it's really snowballed over time. Our first year, we only had about 350 respondents, which is not bad. That's pretty good. But in year 2, we had over 1,000, and now we're, you can see that the distribution based on stage is actually pretty reflective of the state of bladder cancer. So, about 2/3 is the non-invasive bladder cancer. About 1/3 is more advanced disease with a sliver of metastatic disease. And I'm not going to go through all the results because it's not as important as the process. That's what I want to show you, the process of doing something like this. But then we had all the different types of ranked questions. And the way that this works is the darker blue, that is how many respondents said that this particular question was ranked number 1. And then red was how many it was ranked number 2, green number 3, purple 4, exactly, and onward. So you can see that the on the very left, the most of the people ranked number 1, the decision making for bladder removal. And that's probably not surprising to many of you on this virtual webinar who treats bladder cancer. Those who, their disease doesn't respond to BCG. It becomes challenging over time, right? Because you're asking them to make a choice between having a cystectomy or something else, but that something else may create progressive disease and could impact their survival, right? So it is an important question, and patients felt that way too. And the second question, treatments for BCG failure, was the same, number 1 and number 2 most commonly ranked questions. All right. Once we had that, all right, now we need to disseminate the research questions. We need to do something about it. So we did that a couple of different ways. Most importantly, we gave it back to the patients. I mean, how many times in clinical research do we not share our results with the patients who were participating in them? So we sent that back to the Patient Survey Network so they saw that their voice mattered and how we put it together. We gave it back to the Bladder Cancer Advocacy Network. We shared it with all the funding agencies so that they know when they get a question, a research question about bladder cancer, when they're handing out the funding, this is important. They need to know what was important to the patients. And then finally, researchers, we wrote some abstracts and papers so that if someone was writing a grant, they could reference and say, hey, this is important, and here's why. Here's the paper, the reference that shows this is the number 1 question. that's, impacting patients affected with non-invasive bladder cancer. And lo and behold, PCORI, one of those funding agencies, put out a call, because every funding agencies put out, a list of priorities each year, all right? And this particular year, it was really big deal. Bladder cancer had never been featured ever. And that's because PCORI is very big. It doesn't just handle cancer. It handles anything, pediatrics, dentistry, anything. So this was a big deal for bladder cancer to be featured. And what you can see is that it featured on patients with high risk non-muscle invasive bladder cancer, and the decision-making process between cystectomy or bladder preserving alternatives to cystectomy. So we were like, great, this is wonderful, but we have more work to do, right? We now know the research questions. So we've done the first part. How do we get patients into our research teams? Because it's not so easy just to call up a patient and say, hey, join my team. So we created what's called a patient empowerment and engagement research to create partnership with the research team and patients. And this was another engagement award to allow us to do this. But here's what we ended up doing. We created a research training curriculum. We developed a study to address that number one prioritized research question. So I'm going to explain how that was developed. And then we needed to create a sustainable patient expert mentorship model. And so you can see the figure here. The PSN on the far left, that was our first engagement award. PEER, which stands for Patient Empowerment and Engagement Research, was all about preparing patients to join the team. And you can see this is how we engage them. And truly what we wanted them to be confident to join the team. And what we did was we created mentorship with other engaged patients. And we wanted to have a proof of concept where those patients with a research team could actually develop a set of valuable research questions and then have them answered, have them designed. And then the sustainable piece, and I'll just touch upon this, we decided to partner with industry. And that's a very valuable way to get some funding. If you don't have PCORI at your disposal, have a patient, have an industry sponsor some of this, because what they get out of it is that they also get the patient voice when they're trying to understand how to study their own drugs and how to market them. So I think that you can use this and ask for funding in that way if that is, an avenue for you. So just think creatively about how to get that funding and keep it sustainable. So now putting that all together, we had now a patient-informed research question, that question, cystectomy or bladder preservation for BCG unresponsive, non-invasive bladder cancer. We had the patient-informed study outcomes, and we had, now we needed a patient-informed research design. So it's essentially, what are we going to study? And then how are we going to study it? So going back to PCORI's message, they told us in their call, they said, okay, we want these kinds of studies. We want you to study mortality and progression, but we also want you to study side effects and quality of life. And importantly, we would like you to do a randomized controlled trial. Well, anybody this is a webinar, but just think in your mind, there's some of that makes sense, and some of it you're like, is that really going to work? Because it is such a patient preference heavy decision. Do you think you could randomize someone to having their bladder removed? So let's take it one by one. The research questions, cystectomy or bladder preservation. Well, that was a no-brainer. We already published. That's the number one question. I showed you the data. All the patients said that was mostly their number one and number two ranked patient prioritized research questions. So we knew that piece, yes, that's important. But then what about the second thing, the study outcomes? They said, right, mortality and so forth, and they said side effects. Well, we see side effects in urinary quality of life and survival, but we also asked them, what other outcomes do we need to answer for you so that when you were facing this decision, you can make the most educated decision for you? Well, they brought up several others that weren't included. One is caregiver burden, because we know those who decide bladder preservation, they got to come to the clinic often, right? Lots of induction therapies, lots of visits, lots of surveillance. And some of them are older. They need someone with them. Well, that's something that's going to enter their decision-making process. Whether they can retain their bladder, some of that is really important to patients. And then third, how much is this going to cost? We don't study that. So we knew we couldn't just study just the quality of life, side effects, and survival. We needed to study more. And you could see almost 80% wanted all of these things. Then the third was, how are we going to do it? Well, look at this. We asked them, well, hey, would you be willing to sign up for a randomized control trial? Well, I changed the verbiage and had patients help me do that so they understand. So the questions, would you be willing to sign up for a study in which the researcher decides which of the two treatments you're going to get? You know, bladder preservation or bladder removal. Well, look, 90% of people said, no way, I'm not going to do that, right? That's not a surprise to us, but it would be potentially to PCORI. And that's why it's important to ask the question to your patients, like, would you actually sign up? Because before you invest all this time, all this money into a clinical trial, shouldn't you know if the patient's actually going to sign up? And that's why, because we don't ask that question. So when we sent the survey out, we also did some quotes. We said, hey, just write in a free text box, like, what does this mean to you and why are you choosing what you choose? So a couple things. Some patients said, hey, listen, this is a really important question, but the risks, I need to know those risks. I need to see them quantified so I can inform my decision. Some people said, I need that choice based on the experience of others. So that lends itself evidence. That's why this is so important. And then there was some people who said, I need to know not just that the choices and the risks and all of that, but I also need to know how patients actually arrived at their decisions, you know? And so it's really interesting because this is designing. I'm going to show you our design and why this design, was decided. And then finally, what are the financial implications? And there were many other quotes, but I wanted you to just show you how valuable some of these quotations can be, because they can completely help you when you figure out what you're going to study. So this ended up bearing fruit. We decided to create a large pragmatic trial. And again, the point of this talk is not to go into the trial, but rather to show what came of it. We call it Cysto, comparing intravesical therapy and surgery as treatment options. And we wanted to be pragmatic. Pragmatic means that it's not a general randomized control trial. And remember, no one's going to sign up for that. So we did a prospective cohort study where patients could enroll, but they decide, okay? And we get baseline data, and then we get outcomes. And you can see in AIM-1 over here in that box, the primary outcome was their most valued question, or their most valued outcome, health-related quality of life at 12 months. But we had a number of secondary outcomes: sexual function, treatment preferences, decision regret, financial toxicity, how much healthcare are they utilizing, progression, and bladder cancer specific survival. But AIM-2, remember that second question, how do patients get to their decision? We decided to do another set of surveys and interviews to better understand how patients are getting to their decision. And so that's with phone interviews and understanding the different health states and what it matters to patients. And because of that, we're going to be able to answer both of those questions in a very meaningful way. Right now, we needed to do, we have about 32 sites around the country, and we just hit our really big milestone of 400 patients, which is pretty good considering this is a relatively rare population. This is BCG unresponsive, non-invasive disease. We have that engagement structure overlaid. We have the data coordinating center, like I said, that's for statistical analysis. We have the clinical coordinating center, who has all the practice sites and the study operations. But very importantly, and important to this talk, is the stakeholder coordinating center. We call it an advocate advisory board, but essentially it are patients and caregivers who we meet with every month. We share different things. Right now, we're actually working on dissemination tactics, but before we were working on design and how we do the study. So here are some examples of how their input made important changes. The first, well, that's a lot of survey information. Remember, those outcomes, there's a lot of them. They timed the survey so that we could actually say when a patient enrolls, hey, this is going to take you this amount of time. And they placed the questions in priority order, because remember, there's survey fatigue. What if they only do half the survey and they don't finish the rest? Well, which questions are most important, such that as long as they start, we're going to get what we need, and then the other stuff is important, but we can do without it. So they helped us order that. When we recruit, they said, you know what was really helpful? To hear real patients and a real physician, not an actor, but having a video. At the very beginning of this session, what did we see? A video, right? Because it's engaging. We can see that, we pay attention to it. And they helped us design that and videotape it. Every patient who enrolls watches it. They know why this is so important and the value of their input. We added questions like whether a second opinion was obtained. We clarified questions. We asked about radiation. Well, as a urologist, I'm thinking about radiation to treat other diseases like prostate cancer. But they thought history of radiation meant a CT scan in the past. See how valuable this is? You could actually ask a question and get the completely unintended answer that you're asking, right? And then the last was how we word things. We called it a trial, but in patients' minds, they actually said, well, if you use that word, I'm going to believe that you take my choice away. But in this study, we don't do that. We allow them to make the choice. So we just took out trial and we reworded the way the study design was. We'd probably get more patients involved because of it. And so we created this very patient-centered design with patient-centered outcomes with the hope of getting generalizable results. And we're doing that in a couple different areas. John Gore at University of Washington he's my research partner. He's my co-principal investigator. We're doing the same to compare cystectomy and chemoradiation, but reflect in your own practice. Like, what are the two, what are a couple options that you really don't know what is better for patients? How could you apply it in this way? And so this is, we're calling it Crocus. And we're doing that also in cysto discomfort. How often or how long do we let lidocaine dwell? Do we let them visualize the cysto, or do we play music to try to, either distract them or we focus them? And this is a project I'm working on with Florian Schreck from Dartmouth and Yair Lotan from UT Southwestern, and of course, John Gore. All right, so in the last 10 minutes, I promised you, and this is where I want to wake you up a little bit. That was the example. That was the story of how you can do it. And there's a lot of time that went into that. So, you might be scratching your head, okay, that's great, but man, I don't have 10 years to build something like that. Well, you don't need 10 years. I'm going to give you some practical strategies to incorporate engagement into your research. And then we'll have some time for questions. So the first, when you're getting funding, and your funding may come from, again, from industry, your funding may come from, your institution or some other source, I would just argue, include your patient advocates in your budget if it's possible. You don't have to put a lot in there, but you should do something to demonstrate their value. It goes a long way, because then they feel like you actually care about their opinion when you have them on the research team, all right? You don't have to reinvent the wheel. You may say, hey, I don't know how to do patient engagement. Well, let me give you some tools, and these are free. This is the GRIP 2, so GRIPP2 reporting checklist, and you can write that down, Google it. There is a free resource. You don't need any, it's open source or open access. There's a short form, which I have here, and a long form that actually can take you right through of how you incorporate patient engagement in the aim, in the methods, in the results, in your discussion, etc. And there's also an extension. So if you are designing a clinical trial, you're going to put together a protocol. How are you going to do it? Well, there's actually a protocol written. It's a template, free. And I have the sources down there. But when you open it, it's called Spirit Pro, and you literally can download it. And it's like insert, little things here and there to adapt that extension to your clinical trial in incorporating patient-reported outcomes. So a lot of these patient engagement studies, they need their outcomes measured, right? How do they feel about the treatment? If you don't know where to begin, hey, partner with an advocacy organization and find out what that means in your area. For me, you saw it was Bladder Cancer Advocacy Network. And since then, I've been continuing to work with them. We've created a website for patients and for researchers who are trying to find patient advocates so that we can actually build that partnership so that anyone can do that, right? But there are lots of different cancer related advocacy organizations, and I'm sure other foundations for other types of diseases. So, there's us too for prostate cancer, KC Cure for cancer, kidney cancer, and onward. So just look out there about the advocacy organizations and partner, because we're not going to be an expert in advocacy, not all of us. So why don't you partner with somebody and you can mutually benefit? And I said, you can do this today or tomorrow. Well, go to your clinic and engage with your patients. You know what I do? I know my patients, and so do you. On any given day in a clinic, you have patients who you've seen many, many times, who trust you. And, they really understand the disease process. Maybe one day, they're doing well and you say, hey, listen, I really am working on this potential project. I would love to have your partnership, your opinions. Would you ever be interested in me calling you or you joining our team? Because you know so much about the disease, you have so much opinion about this, we would really benefit from that. And just start there. I have a list that I just keep. And maybe you don't even have the question yet. Just start a little list, and then you can go back to them when you do have the question and say, hey, you said you were interested. You pick up the phone and say, would you still be interested? I have an idea. Would love your thoughts. So you could just do that today, tomorrow, and start the process. And then invite those patients to the table. So once you do have the question, have them come over. Invite them to the team. And you need to be very, very cognizant that they may be nervous because they weren't researchers. So this is where your facilitation is everything. You need to bring them to the team. You need to elevate them to the team and say, hey, this person, we're an expert in the research process, but they are an expert in their disease because they've lived it. Ask them to be at your table and ask questions. And then finally, embrace diversity. And I mean that in a number of ways, okay? I do mean it in terms of race and experience and socioeconomic status, if you can, right? If all of these things, and age, right? Gender, because everyone's going to have different experiences to the disease, and they're going to give you different input on how to reach those various populations so that when you recruit to the clinical trial, you know how to reach all these different populations and your results really truly are generalizable, right? But I also mean it in terms of stakeholders. And what I mean is that we've talked a lot about patients, but what about caregivers? What about social workers? What about nurses? Who else? What other voice are we not hearing in this process who might be really important? Payers, insurance companies, because they're going to be potentially using your results, right? So just think about what those are and maybe create a team that reflects those opinions so that when you're designing the study, right at the very beginning, you have those opinions in mind so that you can better, address and disseminate results in a meaningful way. And finally, if you really, really are interested in this, for AUA 2023 in Chicago, and starting in April, we have fortunately been accepted to present a course about engaging patients and communities and research. And Geo D, who is on the very far left, she works in transgender health and reconstructive urology. She's leading this course with John Ellison, who's on the second to the left, doing pediatrics. But we have a really nice, and Yao Yame doing prostate cancer research, and then myself and John Gore. We're teaching this course to really sure that we have a good representation, also to understand if you're working from the ground up, where do you begin? There's lots of resources on the PCORI website that we're going to share, and we would invite you to attend if it's really interesting to you and you happen to be coming to the AUA. And of course, a lot of these courses are made available virtually. So I'll end with this quote, and I'm going to do a small edit. So it's too bad that patient-centered research And with that, I just want to thank my team, because none of this is possible without one. I already mentioned John Core. For anyone listening, this is a masterclass in research. If I could tell you anything, if you can find a research partner who's your good friend, that is at least 50% of the way there, because it makes research fun. You have someone to bounce ideas off of when things get busy. Your other person can really pick up the slack, and vice versa. And I couldn't do anything without John, because he's a great friend, and he is the reason that we can get our work done. I also have a wonderful team, both at UNC, but also the Beacon Patient Survey Network. So all of these names are a combination of patient advocates. You can see that that picture for one of the groups and the leadership summits we did in the very bottom right, and our leadership team for Beacon. All these individuals couldn't do it without it. So you really do need a team, and you need to build trust. And then finally, and I always put it last because it is absolutely the most important, my family's everything to me. And these are my two girls in the middle, my husband at the top, and grandparents and my best friends and all of that. We all come to our work every day, and it's really valuable. But in the end, it's our family that really cheers us on. And so I want to recognize that as well. So with that, I want to just say muchísimas gracias for your attention. And I have my email here and my Twitter handle in the bottom right. And I would love to engage with any questions that we have. We have a good amount of time to do so.